So welcome everyone to Medical Grand Rounds. Before we get started, I'd like to make a brief land acknowledgement. McGill University is on land which has served as a site of meetings and exchange amongst Indigenous peoples. We acknowledge and thank the diverse Indigenous peoples whose presence marks this territory on which peoples of the world now gather. Thank you for being here today. Just a reminder to please enter your questions in the chat at the end of the presentation. And please answer a brief survey that will be sent to you right after the presentation. So I'm very thrilled today to have a speaker from our division of respiratory medicine, Dr. Jean Bourbeau, who's known to most of you. He is a professor with Distinguished Scientist Award in the Department of Medicine. He is a respirologist at the Montreal Chest Institute and senior scientist at the MUHC. He is the past president of the Canadian Thoracic Society, fellow of the Canadian Academy of Health Science, and member of the Scientific Committee Global Initiative, or COPD. He's recognized as a world leader in COPD with over 400 publications in peer-reviewed medical journals. His research includes the Canadian Cohort Obstructive Lung Disease CANCOLD Pulmonary Rehabilitation and Self-Management Program Living Well with COPD. This has contributed to changes in guideline, better practice, and patient outcome. Something that we all face, whatever practice we're in, patients with COPD. So I look forward to hearing your presentation. Dr. Bourbeau, thanks for being here.
Thank you very much. Welcome to everyone, people that are in the room, and a lot of people from remote. Guideline. What the timing could not be better, because when the department asked to the rest division, in fact, this guideline has just been published a couple of weeks ago in our Canadian journal, and for the first time, simultaneously, it's been published in the journal Chest. It is in press. I work with remote here, or let's see. Just for my conflict of interest, I've been leading the guideline in the last three, in fact, since 2017, including this one. Also a member of the scientific committee of GOLD. And very important to know that the slides that are going to be used presenting the guideline are the slides that are used as presented in the CTS template. And I'm going to go in much detail on the methodology, and you're going to understand how rigorous these process of guideline. I don't know how people are familiar with guideline. This has really evolved over time. Society now are almost exclusively producing guideline, following the higher standard of what a guideline could be. Position statement, we have been working during COVID, because we had no choice, but society prefer to go with that guideline. It has its limitation, and you're gonna see, and I'm gonna allude to some of the limitation that it has, and at the same time also, it is the best way of being able, to build the evidence and make recommendation building on the evidence. What I'd like to do, and those are the objective. The first two objectives are really presenting the recommendation, and those are based on three PICO questions, three major outcomes: patient-reported outcome in terms of symptoms, burden, quality of life; preventing exacerbation; and one novelty of the guideline, an outcome of mortality. Then one of the things that guidelines are not necessarily doing, they are answering question, the PICO question, but then when it comes to bring that into a comprehensive approach, very often it's missing. Then there's been a lot of effort, and I'm going to bring that to an important figure in the publication, where we really want this, to be practical and not only answering question, but also bring that into a practice perspective. And it's not easy, and this is where you can detract, okay, from the evidence. You have to be very, very careful, because you don't want at the end the recommendation under a figure and a comprehensive approach to be different or not supported by the recommendation that you have made. Then I'm going to end it on two important topics, one that had been under a lot of radar for, I would say, the last 10 years. It's the benefit risk approach, okay, and the using ICS containing regimen, in particular this notion of increased risk of pneumonia. Where do we stand with that, and how should we use the information we have nowadays? And finally, what I'd like to do is fill the gap of these recommendations into now the practice. And for a very long time, we had guidelines. Then we were adapting based on our practice. Now we have to start looking at real-world evidence, and there are all sort of real-world evidence designed, from pragmatic trial to cohort to health administrative database. And I'm going to allude to that. It gives you some example of how these real-world evidence are important when you have a guideline to position now the treatment into the practice. There is a whole village, quite a community of people working behind a guideline. This is not the effort of one person. We were 4 people on the executive, different respirologists. We had a pharmacist also. We had a family physician, and the methodologist also that works with us, okay, as part of the Canadian Thoracic Society. Let's look now at the guideline first. The objective, okay, of the guideline was really to come up and being able to help clinician. The guideline is on pharmacology treatment. And we have a tendency not to nowadays to avoid, okay, guidelines that are on the disease, because that is almost endless. It takes years, okay, to get to complete a guideline. Then more you cover, less likely you're going to be timely when you report on your guideline. Then we want to come up with a more personalized approach. Do we have the literature for that? That's what you're going to see. And in fact, okay, this guideline provides an evidence-based recommendation from a systematic review with meta-analysis. Then there is a quantitative evaluation on each, okay, of the comparison that were made here to build on the recommendation. And it's expert informed also by remark that I'm going to make some remarks, but in the paper there is much more. And this is on optimized maintenance treatment. It's not about the treatment of acute exacerbation. It's about the maintenance treatment, aiming at 3 outcomes here, as I already mentioned, the 3 PICO question. Important to know what this guideline is not, maybe more important than what this guideline is. This guideline is not about the non-pharmacology. And this is in no way a message that non-pharmacology treatment is less important or not important. And you're going to see we have a figure in the paper that is about the comprehensive approach, because we want to highlight the notion that these patients should not only be treated from a pharmacology point of view, but also a non-pharmacology. And we are not addressing from the meta-analysis the biomarker, unfortunately, that we are using now, blood eosinophil count, although they are included in some remark. And the reason being that the guideline is based on RCT. There are very few RCT that have been done using the blood eosinophil count, and most of the study are retrospective study, subgroup analysis from RCT, and therefore, okay, the guideline in the way we had set the rule didn't allow us, okay, to include, okay, those studies. And by no means this is not going to be used in clinical practice. From a methodology, and I could spend the whole hour talking of methodology of guideline, okay? But just that you know, first of all, there had to be RCT to be included. Second, there had to be an outcome that is either a primary or a secondary or another outcome, but it has to be pre-specified. And if it wasn't pre-specified, then it could not be included in the analysis. The outcome that were considered, I mentioned already, PICO 1, PICO 2, and the novel outcome that sort of delay the guideline to get out, because we had to work quite a bit on that one. And that's the first guideline that we know right now that address the PICO 3 question, which is mortality and a treatment in COPD. Then we've used a grade system, such as analyzing study design, risk of bias, inconsistency, indirectness, imprecision, and other consideration. The Grade Pro tool was used, and you're going to have online in the supplement all the table on each of the comparison with all that information provided. And the forest plot also that is provided. In the main paper, you have the table for each PICO question with the recommendation, but then you can relate it in the supplement to all the analysis that have been done, and all each of these paper, when they are regrouped on one given question or recommendation, are grade to the Grade Pro, and then having as well the result in the absolute in the table format, and you're going to have the result also in the forest plot. I'm going to show some of that. Then the strength of each recommendation, either strong or weak, is established. This is based on a consensus of the group of people that had worked on the guideline. And when lack of data, the panel has to indicate that there is lack of data and employ expert consensus opinion. I'm going to highlight it to some of this in the presentation of the result, but most of what we are recommended are evidence-based and based on the meta-analysis. Some definition, just that we kind of realize that we were talking the same language. We need some operational definition. We are defining in the paper the burden of symptom. I'm going to get to that in terms of using two scale, the MMRC or the CATS, the COPD assessment test, and you're going to see at which level we have divided such that we consider there is low burden or moderate to severe burden of symptoms. But the risk of exacerbation is one of the things that obviously we want to prevent exacerbation, the same way we would want to prevent myocardial infarction and coronary artery disease. In COPD, we want to prevent, the severe one, moderate, and also the severe one. Low risk of exacerbation if there's been in the previous year less than one moderate exacerbation and no exacerbation requiring an ER or an hospital admission. As soon you have one exacerbation requiring an hospitalization, or you have two moderate exacerbation or more, this is considered to be a high risk of exacerbation. I don't know if people know, but the patient admitted with exacerbation, COPD in the hospital, has the same risk of death during the hospitalization and 90-day post-discharge than a patient admitted for myocardial infarction. And we have very good data, to support that. Then mortality is something that we should prevent, and exacerbation and severity of the exacerbation as well. Those are operational definitions. Why they are important? Because they've been used in RCT. Therefore, when we look at RCT, we look at these definitions, then we should be able after to say, can I generalize to my population of patient or my patient that I'm treating right now? This is the Prisma diagram, and you see that where we've been starting, from, put my glass on, from thousands of record and down to 203 study that have been used, obviously, to different PICO question and different analysis. And that has been, obviously, this is part of the process, how this is decided, but which searches study that are excluded on a guideline, you can go back and trace online that these studies have not been retained for the guideline and the reason why they haven't been retained. Let's get now to the recommendation. This is, we we're going to make recommendation from 2023, and I'm going to refer that if there's been a change from the last guideline published in 2019. The first one, and now we are in the PICO 1 question, and alleviating dyspnea and improving health status. Individual with low symptoms burden, health status impairment. We are talking here of the MMRC 0 to 4 of 1, or a CAHS of less than 10. And this is kind of very well accepted, more and more data on these number that reflect that this is mild. Mildly impaired lung function, FEV1 more than 80% of predicted, although these people have COPD, by a reduction in the ratio of FEV1 FVC. Strong recommendation to initiate maintenance therapy with inhaled long-acting bronchodilator. No significant difference between inhaled LAMA or LABA monotherapy. Change from previous recommendation, where in 2019 and before, we were recommending to use a short-acting bronchodilator. All the study that we've looked at have characterized individual with spirometry base, although not all study have compared either LAMA or LABA to placebo with disease severity by FEV1, MMRC, CAHS, exactly as we are stated here. And it's important to know that. However, the panel valued the importance of providing a precise consensus working definition of COPD with mild symptom burden for recommending regular long-acting bronchodilator therapy. We still feel that we're not so good at evaluating also the burden of symptoms. Many times we're not doing the CAHS and the MMRC. You're going to agree with me. And therefore, the patient is going to say that he's doing fine. But you're not really assessing dyspnea by asking the patient, how are you doing? Same, okay, this time we're moving now into a moderate to high symptoms burden group of a patient. MMRC of 2 or more, CAHS of 10 or more, impaired lung function, less than 80% of predicted, and a low risk of acute exacerbation of COPD. Strong recommendation to initiate maintenance therapy with LAMA-LABA dual therapy. This is a change from 2019, where we were recommending only to initiate with a LAMA or a LABA. LAMA-LABA dual therapy is preferred to ICS-LABA combination due to the significant improvement of lung function and lower rate of adverse event, such as pneumonia. However, ICS-LABA combination would be preferred to LAMA-LABA in individual with COPD with concomitant asthma. Second important here, duo as a first-line therapy in patients that have moderate severe symptoms and low risk of exacerbation. And you have here the forest plot, okay? You have the top one on your left looking at TDI, which is a measure of dyspnea, and the bottom left, St. George Respiratory Questionnaire, which is a questionnaire of quality of life, comparing on the left, okay, LABA-LAMA, okay, to LAMA, and then you can show that in both cases, this is statistically significant, although the clinical significance may be okay, questionable, but there is a consistency in the result. If you look on the right, you have the responder analysis, okay, looking at dyspnea, or looking at the St. George Respiratory Questionnaire. Following now with individual with moderate high symptoms, still low risk, who are on LABA-LAMA dual therapy or ICS, we recommend step up to triple therapy. And this is no change from 2019. This is an extrapolation from the very large study, the study IMPACT and ETOS, which doesn't necessarily correspond exactly to these patients, but may correspond to patients that have more exacerbation. Okay, we extrapolated from these study, okay, because also the alternative here that you have in these patients, okay, as you have reached already dual long-acting bronchodilator and patients are still symptomatic, it is obviously to have the non-pharmacology treatment. Pulmonary rehab obviously would be the way to go before doing anything else. And we are very limited to relieve dyspnea otherwise. We do have some approach like the opioid low dose, but we certainly don't have the spectrum of treatment that we have, for example, with pain. And some of these patients now that survive their disease have dyspnea that is quite refractory. And based on that, we consider that moving on to triple therapy would be still a recommendation. Again, on the low risk here and the moderate IL status or symptoms, we do not suggest adding any oral medication. Now, to improve dyspnea, exercise tolerance, physical activity, or IL status, because none of these medication by itself has added or showed to add anything. They are limited study assessing theophylline, which show equivocal change in L status, although there is a modest improvement in FEV1, and the panel places greater weight on the risk of adverse event and drug interaction. And we don't recommend theophylline. And we keep recommending of not against the treatment with ICS monotherapy. There is no place in COPD for ICS monotherapy. Now we're moving into PICO2. Here, the low risk of in terms of acute exacerbation with moderate symptoms burden or L status, impaired lung function. We recommend the LABA-LAMA therapy as initial maintenance therapy. And this is quite aligned with the PICO1 question that we have already mentioned. In this group of patients. And again, the same remark, this is in favor of ICS LABA, except in patients that have concomitant asthma. You know, the result here when we're looking at exacerbation are, although they're statistically significant in terms of reducing exacerbation, duo compared to mono, the top one being moderate severe exacerbation, the lower graphic being severe, may not be as convincing, than the one that I previously presented on the PICO1 question, looking at the symptom or quality of life or even FEV1 that we haven't presented. Preventing exacerbation again, but this time an individual with, again, moderate eye symptoms burden, but impaired lung function and high risk of acute exacerbation. Strong recommendation for triple combination therapy be recommended as initial maintenance therapy. And this is obviously a change compared to 2019, where we were recommending to go with duo, LABA-LAMA, or duo ICS-LABA. And this is based mainly on two major studies, the IMPACT and the ETOS study, that are two large studies that have been done in those patients with moderate severe symptom enriched with high risk of exacerbation. And in these studies with the same class of medication, but two different medications, the results were quite robust in preventing moderate to severe exacerbation as a primary outcome. And that reduction compared to LABA-LAMA was to 25% relative reduction, and even to ICS-LABA to about 15% relative reduction. And this is what you're seeing on the forest plot. There are more than two studies. Then you have on the top figure moderate to severe exacerbation, triple compared to LABA-LAMA, and quite a reduction in the exacerbation. If you look at the number, you have more than a 20% a relative reduction. And if you look at the severe exacerbation, you have about 50% relative reduction in the severe exacerbation when triple therapy was compared to LABA-LAMA. When we were comparing here, triple therapy with ICS-LABA, your reduction is still about 20%. And you have for the severe one, the reduction might be less than when compared with LABA-LAMA. For individual, again, the same group of people, high risk, we do not suggest step down of triple therapy. No change from 2019. The CTS was the first guideline in 2019 proposing against stepping down when people were on triple therapy. And now there is more and more society going that way, because withdrawing ICS in these regimen that contain also long-acting bronchodilator, addition to the possibility of lowering health status and lung function, can be associated with an increased risk of moderate severe acute exacerbation. And this is where in the clinical remark, obviously, we bring in the notion of the biomarker blood eosinophil count, and saying that this is even more important in individuals that have blood eosinophil count of 300 or more. That we have seen, and it's been seen. Okay, I'm gonna present one study on the real world evidence, but in sub-analysis, that these group of patients that had relatively increased to the threshold of 300, then these people are definitively at high risk of having recurrence of exacerbation if you withdraw the ICS. Then again, for exacerbation, this same group of people, we recommend the addition of macrolide maintenance therapy in appropriate patients who have normal QT interval on EKG, no significant drug reaction or concomitant medication, and no evidence of either indolent or active infection with atypical mycobacteria. The benefits against the risk here in terms of microbowel resistance, hearing impairment, and cardiac arrhythmia related to QT prolongation has to be taken into consideration. In the phenotype of chronic bronchitis patient, there's been study with certain type of medication. And this is where, when you look at these studies, we can suggest, okay, from these RCT, that either roflumilast, which is antagonist of the PDE4, or the N-acetylcysteine, which has mucomis, okay, will be then suggested in this group of patients, and this is a change from 2019. We continue to recommend against the use of theophylline or systemic oral corticosteroid, and there is no role for ICS monotherapy. Finally, the last PICO, the PICO 3 question on mortality in individual with then high risk in terms of symptoms burden, moderate to high, or health status as always assessed here in this study by a CATS or a MMRC, impaired lung function and at risk of high risk of acute exacerbation, we make a strong recommendation for use of triple combination over LABA-LAMA dual therapy and over ICS-LABA combination therapy to reduce mortality. Okay, the greatest benefits of triple combination over LABA-LAMA dual therapy and ICS combination is not only on reducing mortality. Mortality was a secondary outcome or another outcome, but was pre-specified in these two studies, but also improving, as we have shown on the previous PICO question, improving dyspnea, health status, lung function, and preventing moderate severe acute exacerbation that were the primary outcome in these studies. This gives an idea of how it is presented in the supplement. Then you have the table with the certainty, you have the number of RCT, the study design, you have the certainty of assessment, you have the number of patients in each of the treatment group, you have the effect in terms of relative, in terms of absolute, you have the certainty, and you have the importance, and under each table, you have the forest plot. Then this is how it is presented in the supplement when you want to refer, okay, to the evidence on which we build the recommendation of the different tables that are presented in the main paper. Let's go now to how can we bring that into an approach that we have a patient in front of us. We're not only asking a question and we want that question to be answered and based on evidence. We want now to take care of a patient. This is the figure that we've changed that figure. This is more of a comprehensive integrated care approach. and important that this approach should not be viewed as a stepwise. Then at the base of this figure, you have different ways that you're going to assess the patient in terms of the treatable threat, the severity of the disease, and the treatable threat that that patient has. Severity of disease in terms of FEV1, severity of disease in terms of dyspnea or quality of life, symptoms burden, severity of disease at the bottom one in terms of the risk of exacerbation and a risk of mortality. Then you have, okay, the different treatment that should be implemented in the COPD patient, starting from self-management medication, smoking cessation, exercise, active lifestyle, vaccination, and inhale, okay, short-acting bronchodilator. Then you have the inhale maintenance preventive therapy, pulmonary rehab, and so on and so on. Then what we say to people, it's when you have identified from the bottom what is the severity of disease of your patient, you should trace a vertical line, and that vertical line will indicate what treatment your patient should have. Then the treatment should not be resumed as a pharmacology treatment, but there is a lot more that need to be done. Then, okay, this is the last figure and probably the most important figure that, okay, that give really trying to take all of the evidence-based recommendation and see now, can we put that into a decisional pathway that we would help more of a simple way for any physician when you have a patient, how do you classify your patient in terms of treatable threat, and what does it mean in terms of the action, the treatment you are going to put in place, and that's again evidence-based. You see on the left the mild, okay, mild meaning here mild symptoms as we have defined and make a recommendation at the beginning, and okay, those are still, you know, we haven't classify in any way patient that would be mild and high risk of exacerbation. Those patients are maybe asthmatic, maybe, I don't know how often these people are in the practice. Then when we're talking of mild, we kind of neglect the notion of exacerbation, as you can see here. This is still an area, okay, that we don't have the answer. Low burden symptoms, long-acting bronchodilator. In real practice, we're going to start with LAMA, rarely on LABA. But this is based on evidence, and when you compare the two from the study we have, then we cannot favor one to the other, except that there are evidence that LAMA are superior to LABA, I didn't show you that, in preventing exacerbation. Then if you had to make a choice, presuming that you might help, in addition, your patient not only on symptoms, but also on the risk of exacerbation, LAMA have a superiority for what has been studied in randomized clinical trial. Then now we're moving into the treatable threat of moderate severe symptoms and into dividing in low risk or high risk. Low risk, first line treatment, LAMA-LABA. High risk, and we purposely indicated in parentheses, increased risk of mortality, because we want people to see, we know this diagram is going to be on all the slides, and then people are not going to read the paper and the legend or the text anymore, except once, see if we're lucky. And we want people to see that patients that have high risk of exacerbation are at high risk of mortality. Therefore, by this treatment, we're aiming at reducing exacerbation, severity of exacerbation, but also mortality. And then going in the other type of treatment. This is kind of a different approach. I almost feel like a cardiologist here, where, and you know, I have the approbation of a real cardiologist. Then the evidence are the best treatment should be based on evidence. There have no reason in 2023 that we should escalate a treatment to reach the best treatment when the evidence are well established what are the best treatment. If the patient continue to have problem, this is where we have to ask question now. What else can I do? And the guideline is not answering this question, going up to obviously the oral therapy, going up to adding non-pharmacology treatment, and so on. Let's go for a few minutes on a topic that has been a very important topic until now. Why? Because through health administrative database, we had discovered about 10 years ago that there were risks for certain adverse effects. We knew that with ICS there were adverse effects. But why pneumonia became so popular as an adverse effect? It's because we can measure pneumonia. It's acute, and it's much easier to assess than cataract, than osteoporosis, than other complication of the ICS. Then it became a way that we can say there is a risk for patient, and for a certain time, people were saying, yeah, certain type of ICS are not as much at risk, but there was never head-to-head comparison. And in many of the observational study, using clinical database or health administrative database, then we know in practice that certain of these molecules were more likely to be used in the more severe patient than the less severe. This is what in observational study we will call confounding by indication. There are ways that you can try to adjust for that, but you can have residual confounding. For the first time, the two studies, ETAS and IMPACT, have the same population. And when they compare, look at IMPACT here on the pneumonia adverse, nobody dispute that there is an increased risk. There is an increased risk of pneumonia with ICS and COPD. That's very, very clear. But when you compare the two, they're very comparable in terms of the type of ICS. And when you look at even pneumonia as a serious adverse event, you could even say that one that wasn't supposed to be more seems to be more here. I wouldn't say that. I'm saying what I can read from that, in the same population of patients, ICS seems to have the same risk of adverse event. That's the bottom line. That was even said in 2016 by the European Medicine Agency, but that was based on meta-analysis. People who like number needed to treat, then you have the graph here. I know clinicians like that very much. The top is the moderate severe exacerbation. And what it's telling you with triple compared to dual LABA is that you need to treat 4 patients for 1 year to prevent 1 moderate severe exacerbation in that high risk for exacerbation group. Down, you have the pneumonia. Already there, you see that we're not talking of the same number. People died in the hospital of acute exacerbation with COPD. They rarely died of a massive pneumonia admitted to the hospital. And those are the number that we, in fact, fit very well our practice. The number need to arm is 33 patients to be treated for a year to arm 1 patient with a pneumonia. But what is arm here? Arm is what? Arm is you have a pneumonia. Let's look at who has the record holder of pneumonia and COPD. We know now very clearly that people that have gold 3 or 4, the more severe COPD, are more at risk of pneumonia. Too bad, because they're the one that seems to benefit the most from ICS-containing regimen. That's a risk factor. We also know that prior community-acquired pneumonia, and we have a lot of elderly patients now with dysphagia, a lot of other problems, and if one of your patients has pneumonia, look for a cause of pneumonia. Don't assume that it is the ICS. And it doesn't mean you're going to stop the ICS-containing regimen. It's going to depend very much of the benefit that this patient has since it's been tried on ICS-containing regimen. If you look now, at the frequent oral corticosteroid compared to ICS, then if your patient ends up with frequent exacerbation requiring oral corticosteroid, it's in no way necessarily better than having the patient on the ICS containing regimen in terms of being armed for pneumonia or other side effects. And the last study, this is a meta-analysis of RCT that have looked at mortality from pneumonia. 58 patients on over 30,000 were on ICS. They were ICS user in the arm of treatment. 33 on the 20,000 were non-ICS with a relative risk of 0.97, a confidence interval of 0.58 to 1.6. These data reinforce the notion that pneumonia-related deaths are very infrequent in RCT, and given the number of patients included, the clinical relevance of ICS and pneumonia mortality is doubtful. It's always a notion of risk-benefit, and we do that all the time in medicine. We work with patients, not only with number. Then we take a decision by, using a drug that would be helping the most the patient and causing as much as it is possible less side effect. And when we have option, we look at option and we make the choice accordingly, according to the severity, according to other comorbidities. Let's end it in the last 5 minutes on this part. This is where we are going. We have to value the real world evidence more and more. Building on our practice, when I've started to practice more than 30 years ago, those RCT were taken. Then there were phase 4 studies that were more for the company than they were for the doctor. And then we were trying to see in practice, where can I fit that? Because RCT have limitation. We all know that. They are the best level of evidence, but they have limitation in terms of sometimes the small number of patients, high eligibility criteria, then how can you generalize to a larger population, short duration, 1 year is a short duration of the treatment. Then the real world evidence would be used to assess safety. They would be used, to assess effectiveness in the real world. They will be used also to compare outcome in the real world to determine optimal treatment strategy and also to identify prescribing pattern, good or bad. And they can be used also for other reasons in terms of resource utilization and also in terms of economic outcome. I'm going to give you the 3 examples, starting with the recent study by Sami Suissa, which has looked quite interestingly at the CPRD, which is a general practice in UK. That database is used quite a bit by this group and other group. And he had satisfied the patient in terms of phenotype, showing that the single inhaler triple therapy was associated with 17% lower incidence of moderate to severe exacerbation among patients with 2 or more exacerbations in the year prior to cohort entry. My reading of that is different than the reading of Semi. My reading of that is very positive. In fact, what he's telling us by these data, it impact and ethos choose the right patient. That's what they did. Because this is the patient that was entry for enroll, in impact and ethos. Then by a real world evidence study, he's telling us that this is the patient that you should aim for triple therapy. Then he also showed that, although that was a trend, you see the confidence interval here, that their blood ESOs that have blood ESOs count of 300 or more, where there was a trend for reaching here statistical significance. At the same time in the study, he showed something very valuable, that the very first maintenance treatment of triple therapy was 44% of the patients were using this inhaler as a first treatment. Then you can ask yourself, say, wow, the physicians were ahead of the Canadian guideline. Okay. Then you have to look at who in these patients had the previous history of exacerbation. 57% had previous exacerbation, but 43% had no COPD exacerbation. And what these real-world evidence are telling us is that there are patients that should not be on triple therapy. It is as important than the message of which population should be on triple therapy. This is a pragmatic trial. Pragmatic trials are really difficult to do. On the left column, you have the patient here that were randomized to single inhaler. On the right column, you have the patient that were randomized to any triple therapy combination, but any inhaler. The primary outcome was the responder as defined here as the CAT, the COPD assessment test, which is an improvement of at least 2, on the CATs. And you can see that there were 47% responder, 40% responder in the non-ellipta, the multiple inhaler, with an odds ratio of 1.31, then a 30% improve in the responder, when you were on single. Then we can ask ourselves, because there was no measurement of adherence here. Is it because of adherence? But it seems, and there are more and more data showing that having the medication in the same device in the real world is doing and giving a better outcome than separating the device. That we have to kind of switch gear in our mind, that it's not true that triple therapy are all the same. At least triple therapy in similar device or triple therapy in the same device. This is a Spanish study recently published in the CHEST, and it's showing here the adherence. This one, you can see from administrative database that there was a hazard ratio of 1.37, which means that, almost 40% improvement in adherence over a year in the single inhaler compared to multiple inhaler. And that was also associated with a lower risk of exacerbation and a lower risk of death. And that's what you see in the graphic on the left, where you have the hazard ratio of 0.68, then a reduction of more than 30% of the moderate to severe exacerbation. In the graphic on your right, you have a reduction in mortality, hazard ratio of 0.668, then a reduction in mortality of over 30%. Kind of reassuring to see in the real life that you have similar result than what we had also in the RCT. It's kind of giving us the information that now we know that these devices are not all the same. It seems to be related to adherence, at least in part, and the outcome is also different. And the final is when to start these medications. And this study has been done, I'm presenting you one, which look at the benefit of prompt versus delay use of the single inhaler triple therapy. And you can see on the left graphic, the time to first all-cause hospitalization, and on the right, the time to first COPD-related hospitalization. And you have an hazard ratio here, at 90 days, prompt versus delay. That means prompt, the treatment had been started within 90 days, where delay, the treatment has been started within 30 days, and delay 30 days to 180 days after the hospitalization. And you can see that there is a reduction, of all-cause hospitalization, and you have a reduction of first COPD-related hospitalization. Back to the cardiologist. What happened to your patient admitted for an MI? Better example. First of all, the patient is not in the corridor in the emergency room, like the second or the third corridor, of the emergency room. The patient is admitted in the coronary care unit. For being admitted in being in the resuscitation room, you really have to have quite a high PCO2 as a COPD. Second, other than saving life, and doing everything this patient need to have, when the patient leaves the hospital, you don't relay the treatment to someone else. You let the patient go with the best treatment. And you don't think, family physician is going to take care of that, or respirologist is going to take care of that. Would you accept that from a cardiologist? I'm sure this would be unacceptable to all of us and the cardiologist. This is what we're doing. And you should care as much of not only the patient admitted and making sure this patient do well when he's hospitalized, but when the patient leaves, what are we trying to prevent? Make the patient less symptomatic, prevent exacerbation, the more severe one, and then this real-world evidence, and there are other studies similar to that have showed the same thing, show that this is an opportunity that you might be losing if you don't use that moment to treat properly the patient, if that wasn't already the case when the patient came. Thank you. I hope that was useful. I can answer some questions. There is 10 minutes.
Fantastic. Thank you very much, Dr. Bourbeau. Fantastic. Really, thanks for this comprehensive review of the literature in this this topic that many of us face. And congratulations really on leading these guidelines. I know that's not easy. I sit on heart failure guidelines and it's not easy to get a room of people together to try to, to try to come up with a consensus. There's a few questions in the chat. I'm going to ask, I don't know who asked this question, but somebody, first of all, are there questions in the room before we get to the chat? Thanks for everybody for coming here in person. Do we have questions from our audience in the room? Okay, so if as a family physician, can you give us an updated summary for moderate and severe COPD treatment? I guess they want a little bit more family physician type approach.
I don't think you, I'll be honest with you. If I understand well the question, maybe not. But I wouldn't separate what the family physician and what the internist or the respirologist is doing. The same way that we don't separate when we treat a diabetic, when we treat a patient that have coronary artery disease, and so on and so on. I think the approach has more to do with how comfortable are you with this, and at which point in time would you feel, okay, that this patient need to be referred to a respirologist? And I think the assessment should be the same assessment for any patient. It shouldn't be driven by your practice as a family physician or a specialist, but as the patient himself or herself. And that's where I would go. Some people will say, I'm not comfortable, I prefer. Obviously, I can trace you a line where you should refer the patient, no doubt. If after these treatment, patients still have exacerbation, very symptomatic, there seems to be a disproportion between the FEV1 and the symptoms, and you don't seem to be able to relate that to another comorbidity. Things seems to be progressing faster than we would expect, then obviously, and any place where you are uncomfortable, for sure. I hope that's answered your question.
Thank you. A lot of this actually reminds me of the heart failure, actually, literature, as you point out. Actually, number needed to treat of 4 is excellent because we rarely see those kind of numbers. One of the challenges that we run into is some of the medications that we use are more costly and require either médicament d'exception or patient d'exception. Just wanted to check everything you're talking about. I obviously assume, ICS is generic at this point. Is there any issues like that you face?
Yeah, access is obviously could be a problem, and guideline should be preceding, okay, what the provincial listing will allow to. But first of all, start with the hospital here. You have access to all of these medication. In fact, the two combination in the same device that you have, and it's been studied in IMPACT, is Trilogy, and in ETAS, it's a Breezestry. The first one is a DPI once a day. The second one is an MDI with Aerosphere. It's kind of a very specialized technology for deposition, and it's 2 inhalation twice a day. Following the provincial listing, because they are on the provincial listing, the problem come with, obviously, is it on the restriction? Because all of these drugs are on la liste de restrictions allégées. They need a code. And the code, there are 3 codes for triple therapy. There is the RE, okay, 385. That's the easiest. Start with the middle one. RE 385, you renew a triple therapy in a single inhaler. RE 386, you're moving from a multiple device to a single device. RE 384, you're going from a duo to a triple therapy. Obviously, we know why is that. It's that the RAMQ want to check on, okay, how is this prescribed? The problem we have with the new guideline now, we have to do representation to the INAIS and ask INAIS to review the recommendation, because you won't be able to start as a first line duo broncho, and you won't be able to start triple therapy as a first line. That means that you're going to have to start these medication in different device. It's going to cost more to the society because different device costs more than the same device. But that's the way it's going to have to be until we get the INAIS to review make the recommendation. We're quite confident they're going to do it. We're already approaching ENAS and the time it's going to take that the RAMQ receive, okay, the recommendation by the Ministry of Health that this can be done. We're not yet there. Access is going to be a problem for the next year for sure.
Fantastic. A couple of other questions in the chat. We have a couple of minutes left. Is there evidence that ICS dose response effect in COPD for mortality, exacerbations for pneumonia risk?
Yeah, they are. Okay, but unfortunately, the best study that have been done, which is IMPACT and ETOS, in that very high-risk population, we don't have that information. But from previous study, is not on mortality because we don't have that information, but on exacerbation, we had some data showing that there was no dose response, that we could go with a lower dose. The dose that is used in triple therapy, for example, in Trilogy, it's the dose that is recommended when you use ICS-LABA, is the 100 microgram of ICS, where the dose in asthma is the 200, and you cannot get confused because Trilogy 200 will not come on the market. For commercial reason, the company has decided not to commercialize in Canada Trilogy 200 for asthma.
Okay, we have time for one final question by Dr. Baudouin. Was there consideration given to the initiation of dual inhalers only in moderate cases with prior exacerbation who have not been on any therapy and whom only mild exacerbations were seen?
Stefan, obviously when we start digging in, and that's one of the limitation of the guideline, because the guideline is as good, that the study that have been done. And the study RCT that have been done, as you know, are not decided most often by us, but they're decided by the industry. Unfortunately, it's always by industry, and very much toward the regulator, because the regulator has obviously ruled, and the industry has no choice, because if they don't go with the regulator, they won't have their drug anyway being approved. In cardiology, they've been able, to do study, coming with design with study, where the question, some of the clinical questions are kind of more important, because in clinical practice, some of the questions remain unanswered. Then I think that would be my best answer, Stefan, saying that we don't have an answer, because many of these the question we don't have the study, certainly not the RCT, and we won't have the RCT. Hopefully, the real world evidence will guide us in some direction. But sometimes it's not final. We've seen observational study coming with conclusion and then doing the RCT, and the RCT doesn't show the efficacy of a treatment. Then.
Fantastic. It is coming on 1 o'clock. Dr. Bourbeau, thank you so much. Congratulations also on advancing this field with all your publications and accolades that you have. And thank you for giving us this very comprehensive review on this topic. Thanks everyone for attending in person and online. Have a great afternoon. Bye-bye.